what I want to do today is to present you some work of our research group. And in my presentation, as already said before, I will also integrate the presentation by Patricia J, who could not come to this conference. But before I do so, I want to point out some basics about substance use and addiction and the relationship with psychiatric illnesses. I know there are a lot of prejudices on addiction amongst the general population, but also amongst people working in the mental health field. So I will present some definitions and show you a causal model and some results of 3 of the studies we have been doing. We all know that adolescents are experimenting with alcohol and drugs. And maybe we all have been doing it. But what is the difference between normal and innocent experimenting and getting addicted? I will show you some ways how what we say is safe substance use. Safe substance use is when you consume in a safe manner. So no injections, no smoking, no daily usage. Consuming in a safe quantities that present no risks whatsoever. Not using to feel better. Not used to compensate for the effect of another substance. For example, when you use cocaine and you get very, very agitated, you mustn't use alcohol to get more relaxed again. No use in situations that are potentially harmful. And avoiding use of substances if you or one of your family members are vulnerable to addiction or other psychopathology like psychosis, depression, anxiety disorders. But when do we say that you are addicted? Addiction is a treatable psychiatric illness characterized by craving, that's a constant need, urge to use the alcohol or drug. Loss of control, physical, psychological or social consequences. Physical like liver problems, psychological, for example, you get depressed or psychotic or whatever. And a lot of social consequences like don't going to your other friends but only to friends who are using also drugs, or coming too late at school, or not go to school at all. Also an increased tolerance to the substance. You need more of the substance to get the same effect. And eventually withdrawal symptoms. And that's one of the things people, it's a big misunderstanding that you need to have withdrawal symptoms to be addicted. There are many people who won't have withdrawal symptoms, but they are addicted. For example, a man who does his work and comes straight home and he needs his drink to relax. This is a man that's really at risk and maybe he's addicted, psychological already. It's also something with a clear neurobiological substrate, and I will talk about that later. In the past, everyone looked at addiction as it was a behavioral or moral problem. It was bad behavior, and you had to stop that, and when you couldn't stop that bad behavior, you were a loser, somebody who has no guts, you don't have any guts to stop. But nowadays we see it's a broader thing. It's a neurobiological developmental condition, and I will point out it to you. The research has shown us that you have to look broader. You have to take two dimensions into account: vulnerability and the biopsychosocial model. Why do people get addicted? It has something to do with the characteristics of the person, and also for the characteristic of the substance. For example, the addiction potentials of the drugs can be very different. For example, you need one or few exposures to heroin or tobacco to get addicted, but there are only a few people who get addicted to alcohol after frequent use. Also, availability is important. It's much easier to get access to alcohol than you get to LSD or heroin or cocaine. And many people don't want to go in illegal drugs, so it's much easier to take alcohol. And one of the most important role of getting addicted is the brain reward system. The brain reward system, when you take a drug or alcohol or tobacco, this system is activated, and what then happens, you get a dopamine release, and that is what makes you feel good. That's why it's so addictive, because when you take it, you feel really good. Remember this, I will repeat this later on. There's an individual vulnerability, and predisposition and environmental factors play a role. There's a predisposition about how many receptors, dopamine receptors you have, and there's also a predisposition for the sensitivity of the reward system. But you have to see it as risk factors. I will explain to you by the risk to get a heart attack. You know, when there is a history of a heart attack in your family, you have a higher chance to get a heart attack. But also, when you have a high cholesterol, when you're fat, when you smoke. It is all risk factors, and the more risk factors you have, the higher the chance to get addicted, to get a heart attack. It's the same with addiction. So the more risk factors you have, the higher the chance to get addicted. And why is it so that after you have been detoxing people, they remain addicted? Many people still thinking, just detox them and the problem will be over. It's not as simple as that. Why? Because sociological aspects play a role. When you just stop using the drug, you feel everything. You see everything, every misery you caused, all the pain you're feeling, all the pain you have been doing to other people. Maybe you lost your job or your family or whatever, and you have to cope with that. And the only coping mechanism you know is by using drugs or alcohol. So it's very difficult to stop or stay stopped after you detoxed. Also, biological changes play a great role. The brain is a very nice organ because it always longs for homeostasis. And when you, for example, drink, and you drink a lot, your brain adapts to that by making more receptors. And the problem is, when you stop drinking, your brain is still asking for that drug because it's adapted to that situation. And that situation doesn't stop when you're detoxed. It goes along much longer, and that's why you have the craving. It can take years till it's in normal balance again. Also, when you use frequently, you get the phenomenon of sensitization. The brain gets more sensitive to the drug. Cues play a role. In the beginning, addiction stands for behavior that was essential for surviving. For example, for hunting, primitive men were dependent on their ability to discern cues for tracking prey, and the reward was that they could kill the animal and take it home and the family could eat. The same thing is about sexual attraction and intercourse. They are strong triggers to survival of the kind. The problem with substances is that it's a much stronger trigger and much better rewarding thing, and that's why it's so difficult to get rid of. Now, what does the brain do when you are all the triggers which are around the way you use, or the situation you use the drugs or whatever, is all stored in your memory. And when you're confronted to one of those cues, your body is directly in the state of using again. Sometimes we see in our clinic, when we are walking with the people in our clinic, and there is tinfoil on the ground. The people who smoke heroin getting withdrawal symptom in a minute. We don't see the tinfoil. They see it, and they get the withdrawal. It's an unconscious thing. And what our treatment is to get all these triggers and cues not from the unconscious to the conscious, so you can learn other coping mechanisms than use the drug. Addiction behavior occurs also by classical and operant conditioning. I don't know how many smokers are here and smokers that have tried to quit smoking, but when you're used to smoke a cigarette when you're drinking a cup of coffee or after dinner, you will see when you quit smoking for a while and when you're having dinner, afterwards you feel the urge to smoke a cigarette. Or when you're drinking a coffee, you feel the urge to use a cigarette. That's how it works. So why the people remain addicted is an interplay between psychological, social and biological factors in relation to the substance. But what are the underlying mechanisms? I told you about the reward system. It doesn't matter which drug you use, all the drugs just have influence on the reward system. But remarkably, these areas are also involved in the development of early socialization behaviors and early joint attention and communication. And when you look at the associated functional areas of the brain, for example, movements, sensations, vision, etc., you see that it's remarkably that they also associated in and activated in attention and impulsivity, in stereotype movements, preoccupations, exceptional memory skills, thus linking addiction to developmental disorders like ADHD and autism, but also PTSD from early traumatization. When we talk about addiction, we also talk about addiction to habits and behaviors, not only substances. For instance, gambling, stalking, shopping, sex, internet and games. These findings have led to the elaboration of a vulnerability stress model that puts addiction into a developmental neurobiological environment interaction perspective with links to other developmental conditions. Here you see that model. And like I told you before, how do I use this? So? Met de muis? Okay. You see here the genetic factors. I told you about it's pure genetic, how sensitive your dopamine system is. You inherited it. Early life events play a role. Sexual or physical abuse or neglect changes the sensitivity of the dopamine system and makes you more vulnerable. Also, current stress plays a role. So when you're in a situation of losing your job or you're at war or whatever, all kinds of stress influence the sensitivity of the dopamine system and makes you vulnerable to get addicted to PTSD, ADHD and autism spectrum disorders. So in summary, addiction is a chronic, relapse-prone developmental neuropsychiatric condition with both neurological, psychological and social aspects. In addiction psychiatry, diagnoses are more rule than exception. We see in our clinic only double diagnosis, I would say. Studies have been predominantly conducted in adults in whom externalizing disorder are most prominent, and especially in men, unfortunately. That leads us to some questions. What do we know about comorbidity in adolescents? Are the studies done mostly in the judiciary system representative for the average addiction psychiatry unit, let's stand the community? Let's try to find some answers, and we tried to find some answers, and that are the 3 studies we have been doing. The first one is a review of the current evidence. Here you see that in this study, comorbidity is highly prevalent. And you see it's more prevalent in clinical studies and the juvenile justice system. In this study, 14 samples, which we systematically reviewed, we saw there are many methodological problems. First, inclusion and exclusion criteria were very different. For example, in some studies, suicidal thoughts were an exclusion criteria, also like psychosis. Second, diagnoses were made very differently. It ranges from highly structured interviews to clinical based diagnosis. And third, in most studies, gender was not taken into account. So we can say complex interaction of substance abuse and psychiatry comorbidity is there. And there's accumulation in juvenile justice systems skews the result towards externalizing disorders. Conclusions: as in adults, dual diagnosis is more rule than exception in adolescents. Main comorbidities are externalizing disorders like ADHD and conduct disorder. And when there are internalizing problems, most of them are depression. Treatment of developmental disorders diminishes the incidence of addiction in vulnerable individuals. But the picture of predominant externalizing comorbidity as found in the current literature, does not totally correspond with our clinical impression. And that's why we did the second study. We encounter more and more individuals in our clinic that doesn't fit the general clinical picture of an addict. Neither do these individuals fit in the mainly group-orientated program we often use. So studies on the prevalence of dual diagnosis do not mention individuals with developmental disorders, neither do they mention women. And that's what we see in our clinic very often. So, to ascertain our clinical impression, a cross-sectional case study was undertaken in our department. And all charts of patients admitted within our catchment area were systematically and independently reviewed. It's a retrospective chart review, and a codebook was completed with a glossary for scoring agreements. ADHD and ASD diagnoses were ascertained according to countrywide protocols, and all charts were reviewed independently by Yildau Heerschop. The intervariability was ascertained by comparing scores by Rutger Jan van der Graag and myself to those by Yildau on 10 randomly selected charts. What we found, as you can see here, are very high kappas. So that means that the charts have been consistently and reliably scored. The chart data were of good quality despite missing data, as one may can expect in a retrospective study. Here we see the results of that study. You can see we saw a lot of internal problems, but the most of are external disorders. But what we also see, as you can see here, is 5.3% had autism spectrum disorder, and that's never mentioned in the literature. When you look at the main drug involved, you see alcohol is the main drug. But when you look more closely and you look at the people who have ADHD and autism spectrum disorders, you see that they use a lot more hard drugs. But I have to make also a remark on this, because this study only concerned inpatients, not our outpatients. But in many cases, the admissions were too short to complete the diagnostic assessments. So if we only take the completed assessments into account, the figures are even more impressive. So you can see here. You see a lot of internal problems, ADHD, and autism spectrum disorders. And when you look at gender, it's even a bigger problem. 12% of the people who came to our double diagnosed ward had an autism spectrum disorder. And also you can see we have a lot of women with ADHD. In summary, this study shows that in our units, comorbidity, as in the literature, is more rule than exception. Mainly there is externalizing psychopathology like ADHD, but also in women. And in nearly 6% of all subsequent admittances for addiction problems, an autism spectrum disorder diagnosis was found, representing 12% of our completed assessments. And if developmental problems are common in a clinical sample, does this hold true for the community? As we heard in the first presentation, substance use disorder is far more prevalent in adolescents than is seen in services throughout Europe. Some cases seem to be overlooked. Developmental disorders, vulnerability in girls and young women related to early trauma. Can these be found also in the community? That's why we had the third study. We made thorough analysis of the most recent data collected every 5 years amongst teenagers in Zwolle and its direct surrounding by means of questionnaires. What we did was a study in a randomized sample of nearly 6,500 individuals with two comparable groups disturbed over the urban and semi-rural area. And what you can see here is the prevalence of heavy substance use. And heavy substance use is defined for cigarettes, 10 cigarettes or more a day. For alcohol, the definition of heavy substance use was 7 occasions of more than 5 glasses and at least 3 times binge drinking the last 4 weeks. For cannabis, it was 6 times over the past 4 weeks, and for hard drug it was any use. Here you see the prevalence of emotional problems and suicidal thoughts. What we have done, what is used is the mental health inventory, and there are 5 questions about mood and anxiety on a 6-point scale, ranging from none to all the time. And the numbers which are in this figure are the only ones who had a 6-point score, so the highest. And when you look at it, it are very astonishing numbers. So there are a lot of, especially girls, with emotional problems, and even also many girls with suicidal thoughts. Here you see the prevalence of single and co-occurring problems. It's remarkable that heavy substance use and double diagnosis increases from 14 years over. Here you see that. This is for girls, and here for boys. So it doesn't matter if you're a boy or girl, both from 14 years up, you see more, the prevalence gets up. This is remarkable because in this study, externalizing problems were not taken into account. There's only internalizing problems, and you see with boys are mostly externalizing problems. Double diagnosis is highly present in some subgroups, with especially those with poor general health, as you can see, 62, and when there is a matter of a history of abuse, 49%, and to a lesser extent to the ones who reported this and, for example, bullying or pessimistic about the future. Overall, the prevalence of dual diagnosis in epidemiological sample was 5%. But what came out of this study, and what has to be our biggest concern, is that there are a lot of girls with substance abuse disorder, with internalizing problems, with a history of sexual or physical abuse, who are not reached by our services. So I will make some conclusions. Addiction is a neurodevelopmental condition with a high degree of comorbidity. In adolescents, dual diagnosis with externalizing problems in boys are well recognized and overrepresented in the judiciary system. Our clinical and epidemiological studies point out attention towards two groups that are currently not receiving appropriate help, if any. Individuals with an autism spectrum disorder and girls with internalizing problems and a history of abuse. Further directions. Of course, more research is needed in the field of dual diagnosis and in adolescents. Child and adolescent, but also adult psychiatry training should include more addiction psychiatry. Services should opt for more proactive approach of vulnerable groups, but this topic will be further elaborated in the next presentation. Thank you for your kind attention.